Hello, everyone, and welcome to Virtual Sages. My name is Dr. Rana Higgins, and I am a minimally invasive and bariatric surgeon at the Medical College of Wisconsin in Milwaukee. Today, I'm going to be talking to you about what is the appropriate workup for GERD prior to surgery in an obese population. Here are my disclosures. I am a proctor for Intuitive Surgical, and I am a speaker for GORE. So the objectives of today are, I'm first just going to give you a little bit of a background about GERD and obese patients, talk about some data that we see in the literature on how to work up GERD in these patients, and then finally wrap everything up with some society guidelines and recommendations, what we have thus far based on the literature. So first of all, GERD in obese patients. So GERD prevalence is as high as 72% in obese patients. This is about 18 to 27% in the general population, so significantly more in the obese patient population. Now, the prevalence of GERD with a BMI of greater than 30 is about 50%. And in BMI of less than 25, the prevalence is 23%. So you can see just with a 5 BMI difference, there's over double increased prevalence of GERD. And other studies show that for every increase in the BMI of 5 kilograms per meter square, the risk of GERD increases by 1.22. So every interval of BMI increase in the overweight and obese population is very significant. So what are the mechanisms? Why is GERD so much more prevalent in the obese population, and why is BMI so impactful? So one idea is that hiatal hernias are much more common in the obese population, secondary to an elevated esophagogastric pressure gradient, that increased pressure gradient increases the risk and rate of hiatal hernias in these patients. Also, baseline esophageal dysmotility, a hypotensive LES, and increased transient lower esophageal sphincter relaxations, and these are thought to be secondary to increased intra-abdominal pressure overall, therefore causing increased sphincter relaxations. And finally, higher transdiaphragmatic pressure gradients are another mechanism for the etiology of GERD in obese patients. So what does the data from the literature show us in terms of how we should work these patients up? So as we all know, the GERD workup for patients should include an EGD, upper GI, pH monitoring, and esophageal manometry. Now, how do we need to change these in regard to these obese patients prior to bariatric surgery, knowing these mechanisms, knowing that patients are at increased risk for all of these things that we mentioned, including GERD? So first, what does the data show us in regard to EGDs for GERD workup in obese patients? So this was a meta-analysis and systematic review published in 2016. It looked at 28 studies, around 6,600 patients, and these were divided into two groups. So group one were patients where findings did not change management, and group two were findings which delayed, altered, or canceled surgery. So what they found here is you can see examples for group one and group two. So group one would be some mild duodenitis, grade A or B esophagitis, H. pylori, and a small hiatal hernia. Group two, where surgery was delayed, altered, or canceled, would be Barrett's esophagus, severe duodenitis, esophageal dysmotility, varices, more advanced esophagitis, large hiatal hernia. So again, divided into two groups based on the findings on the EGD. So as you can see here, of the patients undergoing bariatric surgery, 35% had gastritis, 20% hiatal hernia, H. pylori, and then you can see the incidence of Barrett's or carcinoma was very low, less than 1%. So overall, 92.4% of obese patients who had an EGD prior to bariatric surgery had normal findings or findings that did not alter the surgery in any way, so 92.4%. About 7.6% did have findings that delayed or altered surgery, but again, over 92% had findings that did not change management in any way. And one thing to also consider is that an EGD is not benign. It is an invasive procedure. These patients are obese, so they often require sedation. There's risks of bleeding, perforation, and even more significantly, because they can't just typically get the normal sedation, they have to have more significant sedation. They can get cardiopulmonary complications from the sedation and from the anesthesia. So in conclusion, this study identified that routine pre-op EGD is not warranted based on the current evidence. A selective approach to EGD may be considered based on the patient's symptoms, risk factors, and the type of procedure planned. So a second systematic review and meta-analysis published more recently in 2020 was of 25 studies over 10,000 patients, and these were all non-randomized controlled trials, so 15 prospective and 10 retrospective studies. And these patients were divided into 4 groups now based on their preoperative EGD findings. So you have group 0, no abnormal findings, group 1, abnormal findings that did not change surgical management, group 2, abnormal findings that changed the surgical approach or postponed surgery, and then group 3 was absolute contraindications. So 82% were in this group where they had no abnormal findings or findings that did not change the surgical approach. About 16% had abnormal findings that changed the surgical approach or postponed surgery. But one point that was made in the manuscript was that it's unknown what percent of these patients included those needing H. pylori treatment. So if H. pylori was identified, the surgery was postponed in order to complete the treatment. So that information they couldn't quite flesh out. And so that's the only limitation here, is we don't really know what those specific findings were. And again, very low percentage, 0.4%, that were absolute contraindications to surgery. So this meta-analysis essentially showed that routine pre-op EGD has insufficient evidence demonstrating effectiveness and impact on operative management. So similar findings to the previous meta-analysis. So that's workup for GERD with an EGD. What about an upper GI study? So this is a study from 2019 looking at upper GI fluoroscopy before a sleeve, a study of 1,800 patients over 6 years. All of these patients underwent routine pre-op upper GI, and essentially what was done was the pre-op imaging was then compared to the intraoperative findings of a hiatal hernia. So the intraoperative identification of a hiatal hernia is the gold standard, and the overall prevalence was about 11.1%. Now, the sensitivity of the pre-op upper GI was 32%, so true positive, 32%, so low sensitivity rate. Specificity or true negative was 94%. So upper GIs being negative for a hiatal hernia were very much more accurate than upper GIs that were positive for a hiatal hernia, not nearly as accurate or consistent. So in conclusion, routine pre-op upper GI has a low sensitivity for hiatal hernia detection and does not offer an advantage over intraoperative hiatal exploration. So upper GIs and EGDs, again, neither routinely recommended prior to bariatric surgery. What about pH monitoring? So there's not as much data in regard to pH monitoring, and this was a study published in 2019 of 43 symptomatic obese patients who underwent wireless pH testing and EGD. So overall, 21% or 9 of the patients had a change in surgical management from a sleeve to a bypass based on their Demeester score on the pH study. The 48-hour Demeester score median was almost 40 for those who had a change in surgical management and 15 for those who had no change in surgical management. On the EGD, about 60% of patients had non-erosive reflux disease, so reflux disease that didn't demonstrate any sort of esophagitis. So overall, what this demonstrated was that pH monitoring can be considered in patients with symptomatic reflux, as EGD alone may not capture their true pathophysiology. So because 60% of patients had non-erosive reflux disease on EGD, that indicates that the EGD was not truly capturing everyone who had symptomatic reflux. So in those situations, a pH study can be considered in patients who have reflux where perhaps the EGD does not show a pathology. And finally, esophageal manometry. So this is a study published in 2020 about esophageal manometry, looking at the evaluation of manometry and its utility in determining the presence of a hiatal hernia. So this was a study of 41 patients. They underwent routine pre-op GERD questionnaires, upper GI, and high-resolution manometry. So again, gold standard for hiatal hernia detection and diagnosis is intraoperative, and in this case occurred in about 27% of patients. And what they found from this study was the sensitivity of manometry. So they compared the manometry findings of a hiatal hernia to the intraoperative findings. The sensitivity of manometry was about 91%, so true positive, much higher sensitivity than the upper GI we talked about earlier. Specificity about 63%, so true negative. So a lower specificity, but definitely more significant for the true positives. So in conclusion, this study found that high resolution manometry is more accurate for detecting hiatal hernias compared to an upper GI. So it can be considered a useful tool to determine the presence of a hiatal hernia preoperatively. But again, across the literature, the intraoperative diagnosis of a hiatal hernia is the gold standard and the most sensitive way to diagnose and treat a hiatal hernia. So that's the data from the literature. Now, what does the society guidelines, what do we have out there and what's currently recommended? So this is from 2013. These were guidelines published by the ASMBS in combination with TOS and AACE. So what they identified from these guidelines were that clinically significant gastrointestinal symptoms should be evaluated before bariatric surgery with imaging studies, upper GI series, or endoscopy. So again, no asymptomatic screening routinely is recommended based on these guidelines, but primarily only patients with clinically significant gastrointestinal symptoms. This is another care pathway that was published by the ASMBS in June of 2017. This is specifically for sleeve gastrectomy patients, but can also be considered in, obviously bypass patients are a little bit different, but for sleeve patients, endoscopy, in regard to endoscopy, the guidelines recommend selective pre-op EGD recommended for patients with symptoms of heartburn, regurgitation, dysphagia, and other foregut symptoms. So again, EGD recommended for significant upper gastrointestinal symptoms. Routine EGD can identify hiatal hernias, esophagitis, ulcers, and tumors. However, the majority of patients are asymptomatic and less than 1 to 9% had any change in surgical approach or delayed surgery. So selective pre-op EGD is recommended. Routine in asymptomatic patients really has a low incidence of finding anything significant. For upper GIs, the society does not routinely recommend upper GIs. It causes an unnecessary exposure to radiation and has not been found to impact operative management. So again, focusing on patient with symptoms or patients with a higher prior history of gastric surgery, that is when an upper GI should be performed, but it should not be performed routinely in patients who are asymptomatic. And finally, pH and manometry, they recommend selective use based on the symptoms. If there's a concern for an esophageal motility disorder, or if patients have severe acid reflux refractory to PPI therapy, that can also be considered a reason to consider pH and manometry in the preoperative period. So overall, what can we conclude from the data that we have in literature so far, in addition to the society guidelines? So an EGD is recommended in patients with upper GI symptoms. However, it is not recommended as a routine screening in any way in asymptomatic patients, given the low yield of finding abnormal findings prior to surgery. Upper GI is also recommended in patients with upper GI symptoms or if they have a history of a prior foregut or gastric surgery, but again, not recommended routinely. pH studies are recommended in patients with severe reflux refractory to PPI therapy, but not recommended routinely. And esophageal manometry is recommended in patients with dysphagia, but not recommended as a routine screening. Manometry can also be considered in patients with concern for hiatal hernias. It's more sensitive than upper GI, but again, intraoperative detection of hiatal hernias has been found to be the most sensitive. Gold standard intraoperative hiatal hernia. Thank you so much. And again, thank you for joining us for Virtual Sages.